Good evening, everyone, and welcome. This is a topic we are super excited to talk about. As always, being your own best advocate means taking the information you see here and taking it to your provider. So this is never medical advice. And of course, we'd like to give a big thank you to our sponsors, Bayer, Pfizer, Myovant Sciences, Foundation Medicine, Myriad, Janssen, Johnson & Johnson, and Telix. A couple of housekeeping. This is an interactive webinar. If you have questions at any time, feel free to use the questions panel. Ask them at any time they come to you. And now I would like to introduce our founder, Rick.
I'm here. Is my camera on yet?
No, it's not on yet.
Well, it will be now.
There you are.
Hello, everybody, and welcome to, I think this is our second webinar of the year, but we have a lot more coming. We are really, really thrilled and honored today to welcome back one of our most popular advisory board members, Dr. Rachel Rubin, who has been a superstar for us before and will yet again be today. And she promises us that we have yet another superstar, Dr. Tracy Sher, and we're going to be talking about a topic that not a lot of people know about, but I guarantee may possibly change your world. Some of you are not familiar with AnCan. I know that you're new to the AnCan platform. So we have about 30 virtual presentations a month for, I think, somewhere around 10 different situations and conditions. And if you're not already a member, or if you're not already a participant, sign up. They're all free. Sign up for a reminder for whatever interests you. And I think that you will find that our support groups are a great experience. We run them a little differently to other people, and hopefully you'll find that it's just like sitting around the kitchen table talking to other people. So with that, again, huge thanks to Dr. Rubin for helping us put this together, and we'll welcome you to what is a pelvic floor physical therapist and why you need one.
Is it my turn now, Alexa?
It is your turn.
Oh my gosh, I cannot believe this group. We have over 100 people listening. I couldn't be more honored to be here, a part of AnCan's mission and what they do and how many humans they help, how many couples, how many patients, how many just care teams. And I learn every time I come onto an AnCan webinar, and I just love the energy of the group. And we did a great webinar not too long ago. You probably still watch it, about cancer, chronic illness, and intimacy. And people loved it. They loved it so much. They wanted more detail. And so we came up with this idea of diving a little more deeply in one topic that is so under discussed and talked about, and that is pelvic floor physical therapy. We can go to the next slide. I want everyone, if they want to follow me on social media, it's not because I need more followers, but because I talk loudly and I support all my friends in this space. And so your sexual health, your quality of life, it matters. It matters very much, and it doesn't always feel that way when you have a 10-minute doctor's visit. And so my social media is really geared towards helping people advocate for themselves, get good information, get evidence-based information, and loudly advocating for themselves. If you're not a social media person, we do have a newsletter at rachelrubinmd.com. I promise I don't spam you, though I do spam a little bit with pictures of my children, so I do apologize for that. We can go to the next slide. Again, I love giving people resources. And so for any women on the call, the International Society for the Study of Women's Sexual Health is an incredible organization that allows you to find providers who genuinely care about sexual health and quality of life. So whether you have, I guess really anyone. If you're just a human on earth who cares about their sexual health and quality of life, this is a really nice way to find providers, especially if you are female or identify as female. And then there's the Sexual Medicine Society of North America, which can help if you are male or identify as male. We can go to the next slide. We got some popularity this year because we realized how bad it really is out there. This was a viral article that went on in the New York Times, one of the most shared articles in 2022. 2 million people shared this article about the fact that half the world has a clitoris. Why don't doctors study it? And in the New York Times, a full page in the science section, we really got to dive deeply about how people just don't really know their body parts very well. They don't understand them. No doctor ever explains it to them. In fact, you can see in the top right corner there, I'm examining a person and she's holding a mirror and she's looking with me and I'm talking to her. I'm saying, this is your labia majora, this is your clitoris, this is your labia minora, this is your pelvic floor. And if you look there next to the picture of me at the bottom, there is a pelvis there that is covered in muscle. The pelvic floor made it to a full page of the New York Times. And since then, there's been a couple articles about the pelvic floor. But this went viral because people read it and said, oh my God, in 2022, why don't I know this? Go ahead, you can do the next slide. We also had incredible exposure with this incredible article. If you care about someone in menopause, or you yourself are in menopause, which means you are past, 45 and entering this world, this is a must-read article, and I'm happy to share all the links if you don't get to the New York Times. Must-read article that really goes into, wow, maybe I didn't get the best advice from my doctor in a 10-minute visit. Maybe they weren't educated, and less than 7% of doctors are adequately trained and educated about menopause, which is infuriating. And again, following us on social media, we're yelling and screaming because we're trying to get information to as many people as possible, because it's hard. I could see one patient an hour, but it's barely a drop in the bucket. So we talk to anyone who will listen to us. One more slide. I got a couple more, but there was also this great article about the life-changing magic of a urologist. You think that, oh, I must go to my primary care doctor or my GYN, but many urologists like myself are trained to really care about quality of life issues, whether it's erectile dysfunction, pelvic pain, urinary issues like leakage, or urinary urgency or urinary frequency. We actually care about these issues, and we talk a lot about these issues. Go ahead, next slide. I do 4 things as a sex doctor. I'm a sex doctor, right? I'm a urologist with a fellowship training in sexual medicine. I do 4 things. I deal with issues of desire, arousal, orgasm, and pain. And they are 4 things, but they are very challenging and complicated. And it's really important that I get to know my patients, that I spend a lot of time learning about them and finding out what it is you care about. Because if I don't know what you care about, what kind of sex you want to have, or what kind of sex you wish to have, or what kind of sex you used to have, I don't know what tools I can give you to enhance your quality of life. And it really does take time getting to know people. We can go to the next slide. And it often is kind of a puzzle, right? People are complicated, right? They come from, everyone has a different background. Everyone was raised thinking about sex a different way. People have different partners. People have different comfort levels in how they talk about these things. But what you want matters, and what you think matters, and what you care about matters. But if your clinicians don't know that, they don't know how to help you. And so I often work in a team, and I'm going to introduce one of my favorite team members on the planet. We can go to the next slide. I work in a team. I work with mental health professionals like sex therapists. That's on the right there, ASECT, AASECT. You can find a sex therapist through ASECT, and they can help you talk about sexual health and educate you. But the other team member who I work just as frequently is what's called a pelvic floor physical therapist. Your penis is just a muscle. Your clitoris is just a muscle. The muscles that surround the vagina allow penetration to happen. It allows you to hold urine. It allows you to let stool completely out. The pelvis is the workhorse of the body, and it is so underappreciated. It's actually insane. They don't teach us anything about the pelvic floor in medical school, nor do they teach doctors who deal with musculoskeletal anatomy like orthopedic surgeons or neurosurgeons. They don't teach them anything about sexual health and genitals. So in comes the pelvic floor physical therapists, who are the most incredible geniuses when it comes to understanding urinary and sexual health conditions and how the musculoskeletal system affects them. You can go to the next slide. My very dear friend is absolutely one of the most incredible humans I've ever met, to be honest. If anyone thinks I do a lot or that I'm impressive, Dr. Tracy Sher is really close to none. I mean, literally an N of one. She is her own powerhouse. She has this website called pelvicguru.com, which provides education for lots of pelvic floor physical therapists, provides access to patients who can go onto her website and find someone in their area, find someone who does men's health specifically, or women's health, or sexual health. And she provides incredible education to pelvic floor physical therapists. And I have seen the education and the advocacy of pelvic health professionals up-leveled by 1 million in just the last 5 years. And it's much to many people, but especially Tracy. And the other thing Tracy has done, you can go to the next slide, is provided incredible pictured content. She has hired an illustrator, and she basically has incredible pictures, art that we can use in all of our education tools. So you can see that vulva at the bottom there. We have vulvas of every shape and color and size, and also can give education that represents many different kinds of people. You can go to the next slide. You can see detailed anatomy of the penis, of the prostate, of the bladder, of the rectum. And so we can teach, because of what Tracy has done, we can teach people with so much more clarity and education. You can go to the next slide. It is so fascinating how responsible the muscles and the nerves and the musculoskeletal system is for sexual health and quality of life. Orgasm is just a reflex. Needing to urinate is just a reflex from the nerves. So what happens in your back actually matters with what happens to your sexual organs and your urinary bladder and your bowels as well. And so if you have surgery or radiation or chemotherapy or anything in your body, medications, it may alter this anatomy. And when you work with a team that understands it, we can maximize your quality of life. You can skip ahead too, actually. And so again, these are all pictures from a pelvic guru, and we use them to educate loudly. I just got done showing this picture to a group of 10th and 11th graders. I spent about 20 minutes just showing them these pictures, explaining to them how a penis works, how a clitoris works, how they cannot work and bad things can happen, how to understand consent and pleasure and body autonomy, how to know when to say no, how to, explore. And it really matters. Education matters to all people, because the 10th graders don't know anything, and it turns out the 70-year-olds don't know anything either. And that's sort of this universal issue that we're dealing with, is the lack of education, the fact that these are private parts and shouldn't be private parts. And so you can go ahead. This is just my last slide. Again, if you want to sign up for our newsletter, follow us on social media. But I'm going to introduce Dr. Sher and have her teach you what it is a pelvic floor physical therapist does, because they will change your life. They will change your life forever. They spend time with you, they understand you, they know you, and they will make every aspect of your quality of life better. So I am, without further ado, I can't wait to learn. I always learn when Tracy speaks, and so come on up, it's your turn. Is she here? Is Tracy here? You got to go off mute.
Tracy is here.
I am here. Thank you so much. I really appreciate that super kind intro, as well as all the other information you supplied. Thank you so much. I think we are a dream team, is what I'd call us. We really are a dream team, and I am so thrilled to be here, and I'm honored. Thank you. So are you able to see my screen is the next question.
Yes, we can see your screen.
Okay, great. So I'm going to go ahead and share my slideshow then. And what I'm going to do is, there we go. Okay. So yes, let me introduce myself a little bit, and I do really appreciate the already amazing introduction. I have been a pelvic physical therapist for the past 23 years, specializing in, of course, pelvic floor, but also orthopedics and neuro. I've also been a sex counselor. I've been trained specifically in sex counseling, and I have my own practice in Orlando, Florida for the past 10 years. And I've strength and conditioning and pregnancy and postpartum certifications. And I really specialize in complex cases. So I see cases from people that come from all over the country at this point, or the world, to see me for very complex, specialized pelvic floor cases. And I get an opportunity to teach around the world. I was recently in Dubai. I've been in Turkey and Israel and the UK and France. I go all over the world teaching about pelvic health. I'm really passionate about it, and I'm sure you'll see that'll come through. So our goal is to continue to educate pelvic health therapists as well as physicians on the pelvic floor and the functions and the ways that we can help patients with all sorts of conditions. And so I was going to start with this pelvic floor epiphany story, but I actually want to share two other stories that I think would be even more appropriate for this particular talk. And this one really stuck with me. I had a patient come to me, this was years ago, and she was crying hysterically. And she said, you know, I finally made it through all of my cancer treatment. She had gynecologic cancer. And she said, I finally made it through all of my treatments. And I realized that I could no longer have sexual intercourse at all with my husband. And she was really, really upset. And so she went to multiple physicians and she said, I'm just looking for help. I'm really struggling here. I'm just not able to have any kind of penetration. And I was hoping to get back to that. At which point one of the physicians said, and I'll never forget this, he said, isn't it enough that I saved your life? He said, don't worry about that. And this broke her heart because she really was hoping to get back to life and realized that what they did was fantastic for her, but she felt like, now what do I do? Is this the best it will get? And why I remember this story is we worked closely in pelvic floor therapy to figure out ways to help her in this way. And when she was able to get to that goal and be able to have sexual function again and be able to feel that she could do that, and that's not always the end goal for everyone, but in her case it really was, and we worked hard with her. And she was so thankful that she felt like she got her quality of life back, not only in the sexual health way, but in other ways too, in terms of her function and mobility. And she was just told that, you know, isn't it enough that we've done this far? So just know that if you feel like, I feel like we're hope givers. We provide an opportunity to improve the quality of life in those that we touch as pelvic therapists. And it's not simply just about going through exercises or what you hear. When I tell people that I'm a physical therapist, they say, oh, so you do knee exercises. It's like, well, exercise is a part of what we do. We give a lot more in terms of quality of life and a lot of hope to patients, depending on their specific and individual conditions. And then I will never forget too, another patient had prostate cancer. He went through a prostatectomy and all the treatments he was supposed to go through. And he was also really upset because he said, well, now my physician said that I've reached a point. It was a few weeks after the surgery. And he said, I don't want you to wear any kind of undergarment anymore. I don't want you to wear any kind of pads. It's time to just go out in the world, and if you leak, you leak. And he was devastated by this. He said, well, I don't feel comfortable. I feel like I might still leak urine, and I don't want to do this. I'm going to church on Sunday, and I'm really scared. And the doctor said, you're just throw yourself in there, and if you leak, you leak. It's okay. And he felt really embarrassed by this, and he said, is this all I have to look forward to? So again, the opportunity to be able to say, we can really help you with this, and there's lots more that can be done with this diagnosis and where you are with the leaking, and there's a plan that we can put in place for you, was really, really helpful for him. And again, he reached his goals where, again, it's not always 100%, but we certainly can get as close to the goals as possible. And he was not leaking anymore by the time we finished about 4 months of therapy. So it really can make a difference when people think that they just have to suffer alone or don't have support. We can provide that. So I thought that was helpful. Now, my pelvic floor epiphany 23 years ago, I had no idea what pelvic floor was. I was a student at the time. I was finishing up at Northwestern in Chicago and had an opportunity to do a rotation, a clinical rotation. And every time I saw a patient, I didn't even know that you could do internal therapy. And every time I would do some sort of internal therapy work with someone, they would say, that's really strange. You're touching something that gives me the same back pain I've had for 10 years, and no one's been able to figure that out. Or another patient would say, I can't believe this. This is the hip pain I've had. And I've had hip surgery, and I've had, you know, someone would say, I've been to chiropractors, I've been to orthopedic surgeons. Why are you inside my vagina? And why are you actually creating the same pain? This is the pain I've been telling people for years. And it was this big epiphany that, wow, this pelvic floor, these muscles there are responsible for so much. And it's not just what we see in terms of function, bowel, bladder, and sexual function, but actually it impacts our back, our hips. It has a huge impact on the whole system because they're all related. So this was a big epiphany for me, like, wow, I think I can really make a difference. And I'm finding things that people have missed for so many years. So what are the pelvic floor muscles? We'll go over that so you have an understanding of what we're talking about. This is them they're under disguise right now. And so the pelvic floor basically is a bowl of muscles inside, and there's 3 layers. All of them attach within the pelvis, and they really stay within the pelvis. So they're not really crossing any joints except at and near the sacroiliac joint with the ligaments. There's skeletal muscle, so similar to what you would do with a bicep type of movement, you actually can contract and relax the pelvic floor. It's a hard concept for people to know, like, wow, you can really contract and relax the pelvic floor muscles, but yes, you can. And they closely interact with the hip rotators. So actually, they're deep hip rotators very close to the pelvic floor that actually also help with hip rotation. So it's very closely related to the hip and back as well. And then to take it a little bit further, what the pelvic floor does, there's a few different functions. There's sphincteric. So this is when someone says, keep the pee and poo off the floor. You basically have there's sphincters around the urethra and there's sphincters at the anal area. And that's what, when you think you have gas coming, you might try to squeeze the sphincter a little bit and that prevent that gas from coming out. If you think you're going to urinate, you might try to squeeze that sphincter a little bit there. So there's sphincteric support. Some of it's voluntary, some of it is not. Then we also have and that, by the way, that's one of the first layers of the pelvic floor. Then we have what's called the sump pump, which is actually that the pelvic floor acts as a blood and lymph pump for the pelvis. So it's actually helping with the lymphatic system in that area. Then, of course, there's sexual function of the pelvic floor. So that is essentially where we're looking at arousal functions and orgasmic functions. So a lot of people don't realize that the pelvic floor muscles help with the entire arousal process. They plump everything up. And then when there's an orgasmic feeling or a sensation and all the things that go with orgasm, the function of it, that's all pelvic floor as well working. It's basically coordinating that way. Then synergistically, they work closely. So the pelvic floor muscles, I'm going to show you some pictures, they work very closely with the abdominal wall, the diaphragm, the back muscles, and the hip muscles. So there's a very synergistic, it's not just isolated to one area like the bicep is. There's a lot more going on that it's connected to. And then finally, supportive. All of our organs that are sitting there that you think about, your bladder, your uterus, and any of these organs in there, liver, all of that is actually helped. That it's the final vestige. It's basically the final frontier here where that's holding everything together is that pelvic floor. So it has a lot of different functions that a lot of people don't realize how important it is. And so this is the first layer of the pelvic floor, and we should do a quiz at the end to see if everyone remembers this. But I'll just quickly go through. We have the superficial transverse perineum, and that's basically separating here. You can see in this model, and we will show other anatomy, but for now, in the cis female model, we have essentially the vaginal opening and the rectal opening. So you have the external anal sphincter, the superficial transverse perineum, the bulbocavernosus muscle, and then the ischiocavernosus muscle. And that's what makes up the first layer of the pelvic floor. Oh, and then, I don't know how to go back. Let's see, nope. I might have to come out for a second. And then we'll go back here. There we go. Okay. So the second layer is made up of the deep transverse perineum. So another part of the perineum that's between at the bottom there. And then also the sphincteric support muscles around the urethra. So that's super important that they're actually they're more involuntary there, but they can still be super helpful in terms of support. And then the third muscle is what we think of a lot of times when someone says, do your Kegels. We think about these types of muscles. This is the deep pelvic floor muscles. And there's lots of different ones here, but typically we talk about the levator ani group. So they form different slings around, and they actually go from the pubic bone all the way to the back to the tailbone area. So they sling around, and they're super important. So they help with functions in the front and the back of the entire pelvis. Very important. And then there's other deep muscles that we see a lot too, the obturator internus, which is a hip rotator muscle, and all these deep muscles you see in the back, the piriformis, and other deep muscles there. There's coccygeus around the coccyx bone. So there's lots of different muscles in this whole pelvic floor region. And then it's also important to know that this is all working together. So as you can see, this is a side view, but as you can see, we have the clitoris here, and then you'll see there's the urethra and the bladder, the vaginal canal and the cervix, and then you have the anal rectal canal here. And they're all, I mean, all of this is supported underneath by the pelvic floor. That pelvic floor bowl is really important for support of all of that. And then you'll see here too that we have the diaphragm. This is super important that this is also related to this. So here's a little trivia thing for you. When you take a nice deep breath in, relatively speaking, your pelvic floor drops a little bit. And when you take a breath out, the pelvic floor pulls up. So it relates to the diaphragm movement and also where the pelvic floor does. So when we exhale, our pelvic floor should contract a little bit. So that's the movement. So it is interrelated there. So now I'm going to actually have you do a fun exercise with me. And the only thing that's hard for this is that I can't interact with you or find out if you're participating. And no one will know, because even if you're at home and someone's watching you, they won't be able to tell. But what I'd love to do is have you visualize a pelvic floor contraction. Some of you may think you're doing it right, and some of you may not even know what a pelvic floor is yet. You're still learning. But essentially, a pelvic floor contraction is very small, and it's going to be felt around. There's different cues you can give. So if you have a vulva and a vagina, you might be thinking contract around the vagina, that opening there. Or you might be thinking contract around the anus. If you have a penis and testicles, you might be thinking lift up the penis and draw up your penis up. Think about lifting it up and the testicles up. At the same time, you might be thinking of also drawing up your anal muscles or closing around the anus. We can get fancy and give all sorts of cues. I've found sometimes using Star Trek cues or portal cues, all sorts of things helps patients, or thinking about a flower closing and relaxing and opening. Sometimes people think about a jellyfish, the way it moves. It's up and down and up and down. So there's lots of cues. So what I would love for you to do is think about sitting, if you can, if you're sitting right now, if you can think about feeling your genitals, that genital perineum area. Can you try to do what you think to be a contraction of lifting up, tightening around the vaginal opening or the rectal anal opening, and seeing if you can hold that for a few seconds, and then see if you can let it drop again and relax. And then we're going to have you contract again. And this time, let's see if you have the parts, try to see if you can lift around the testicles, lift, 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 contract, tighten up around the anal area, and relax. So if you're feeling like it's hard, that's exactly what we help with in pelvic therapy, is to see, can you do that isolated contraction? And then can we help you do it with other muscles as well? Now, I will say that 50% of people do them incorrectly, and that's part of the reason why they need some help and assistance, because it isn't something that we all know how to do immediately. It's not as simple as showing a bicep curl. And then the other thing you can think of is when you do belly breathing, what I want you to do is think about taking a nice deep breath in, letting that belly come out, and then seeing if you can feel that pelvic floor is dropping a little. It's going to feel very light. And then as you breathe out, the belly should come in and the pelvic floor should drop, should pull up a little bit more. So those are things just to think about in terms of breathing and how there's a coordination. So the reason why this would be helpful, we have something called the knack. If I were to cough or sneeze, so if I cough, the pelvic floor, I'm breathing out, the pelvic floor should contract so I don't leak. So if you cough, you should contract the pelvic floor a little bit, tighten it up a little bit. And don't get discouraged if this is hard. This is something that we teach all the time, but it can take a little bit to get used to. And because I can't see all of you, and if there's faces that are saying they don't know what's going on, I'm not able to see that yet. So I hope you are finding that helpful. So some of the things we see for pelvic floor symptoms that can be helpful to know about, you might see tightness of the pelvic floor showing up as pain. There might be difficulty in urinating or stop-start types of urine stream. Might be difficulty with defecating or constipation. So you feel it's there, but you're just not able to let go. Though there can be gut issues, there can also be problems with the actual sphincters, allowing it to relax. So there's a tightness there. We find a lot of people have tightness of their sphincter, their anal sphincter or pelvic floor muscles that prevents them from fully emptying. They might say, I go 5 times a day, but I don't feel like I ever really emptied my bowel. There can be pain with penetration, pain with orgasm, or even arousal, as you'll see down at the bottom. Urinary incontinence, so leaking in that way, and bowel incontinence, so leaking again, any kind of urinary or bowel leaking. can actually be tightness. Even though you think of it as only weakness or decreased tone, it can actually be also with people who have tightness there. And then for decreased tone or coordination or decreased coordination of the pelvic floor, we see also urinary incontinence again, leaking, uncontrolled flatulence, not able to control gas. It just comes out when it's going to come out. Fecal incontinence or leaking, prolapse, pelvic organ prolapse, and decreased sexual sensation. We do treat some patients that have both, for example, prolapse and leaking, and also have pain with intercourse. So there can be multiple things going on at once. And this is exactly why it helps to see a specialist, because we can deal with all of these things per that individual. So what do we actually do? So as Dr. Rubin stated, I actually am so passionate about meeting with all the different pelvic therapists around the world. And we have these groups, and we have thousands of people in our groups. And we just got together recently at the Endometriosis Summit, but we meet at all different kinds of professional organizations and do lots of teaching. So this was the most recent one we had in Orlando. And it was really fantastic to get everyone together. So what do we all do? We're super passionate about helping you. I just wrote a few things down, and I really hope that we can talk more in the Q&A, but we're passionate pelvic health professionals with graduate degree education levels. We've completed specific advanced education on pelvic floor function and how it relates to the whole body. So we also, a lot of us have additional specializations, whether that's sex counseling, oncology, neuro, orthopedics, and spine. So we are really passionate about getting as much education as we can to help our patients. It's much more advanced than general physical therapy. We go into a lot more courses for pelvic health. And we really do. We love to help patients. I haven't met a pelvic health therapist yet that isn't just overjoyed to help patients. They really love it, and we really look forward to it. And then I feel like we act as case managers. So for example, I feel like sometimes, and you may relate to this, patients go from place to place. They might go to their oncologist, or they might go to a neurologist, or they might go to their gynecologist, but they feel like it's compartmentalized care. And what I feel like we do a lot of times, we get to spend about an hour a lot of times with our patients. So we get to really help coordinate care. I'll say, do you want me to contact this physician, or do you want me to help you figure out where you need to go next? It makes sense for you to see this physician next and maybe work with this person next. So we do a lot of case management, which is one of my favorite things that I get to do in my career, is I get to do a lot of that management to help patients really, it's navigating the journey of this is really hard, and having that opportunity. I think this is when people say pelvic therapists save lives and help lives. I feel like we really do a great job of helping you manage your case and get you on the right track. And really, a lot of us say that, we become best buddies with our patients, and we really like helping them on their journey. So it's a wonderful profession. And a lot of our patients say things like, why didn't anyone tell me about this sooner? Or why did I have to seek this out myself? Why didn't anyone just suggest this? And this, by the way, can be anything, any person having a baby, or having cancer, or having MS, any of these kinds of conditions. They always say, like, every person should have this as an offering that they, should potentially get, because it can really help you with all these functions. So do we do internal exams? We do, but it's not mandatory. It's absolutely not. We can do so much more if someone doesn't feel comfortable with a vaginal or anal rectal exam. We can certainly start with a lot more other things outside the body. So I don't want you to ever feel discouraged if you think you have to do something internal because you hear pelvic health therapist. And then timing, a lot of the clinics might be 45 minutes. We tend to do 60 minutes. I live in luxury, and I do 2-hour evaluations, but I'm very spoiled because I have my own practice. So it just depends. But you have a lot of time, much more than usually a physician office. And then really, we just tell you to show up in comfortable clothes and something that you can move in. And then we often have you maybe undressed just where we need to have to look at something, but we try to keep you as covered and comfortable as possible. It's really, and it's always individual, one-on-one. You're not in a group of people with this kind of therapy. It's very individualized. So I do have some slides here. I'm going to go through these quickly because I don't think that's why you're here to see all the research, but I did want to show you though that pelvic floor disorders are common. And you see in a variety of different groups that there's 46% may have at least one pelvic floor disorder, for example. And when you see this in other groups that at least with women, there's 34% have some form of pelvic floor condition, and 69% of those in that 34% had urinary incontinence, and 9% had both urinary incontinence and fecal incontinence. So you can see how there's definitely things that are going on that we can address in pelvic floor therapy. So really, pelvic floor therapy is recommended as a first-line, low-risk, minimally invasive therapy for preventing and treating pelvic floor dysfunction. And again, it's all sorts of diagnoses, from pain to overactive bladder to pelvic organ prolapse, pain with intercourse, deep dyspnea, vaginismus, where you can't have any kind of penetration, vulvodynia, pelvic floor myalgia, which is muscle pain. And it improves the quality of life is what we continue to see. Having pelvic floor muscle training or pelvic floor therapy actually improves quality of life. So across all of these research, you can see it's just basically there's significant improvements in all measures. And I think that's important to know that we can back this up with research as well. So what do we do in a pelvic floor evaluation? We might be doing myofascial palpations to see if we're finding reproduction of symptoms, to see if someone does have symptoms. We might be looking at pelvic floor tests directly, either outside, externally, or internally. Coordination of the muscles, tone of the muscles, strength of the muscles, ability to relax. We do special tests. Sometimes there's a problem actually going on at the spine that we catch, or the hips, and it's not really in the pelvic floor. So we're able to say, wait a second, in this case, it's actually this. I've caught patients with specific kinds of issues in the hernias that were being missed that they thought was a pelvic floor issue. So sometimes we can catch other conditions as well, including hormonal, dermatologic, and other kinds of medical conditions. So we work closely with other physicians to make sure that we're looking at all of those things. So as Dr. Rubin said, we're looking at everything. So here's some of our images again. We're looking at the diaphragmatic area and all of the spine and the nerves coming through to the pelvis. You can see how it's all connected, right? The spine here with the muscles going through and down, this is all connected. So we want to look at the entire system. And then again, we can do the internal therapy where we're going into internally. And then we also, again, have positions that we help patients in when we do internal anal rectal exam, if that's indicated. Not everyone needs that, by the way. And then, of course, we're looking at, and a lot of people don't know how many muscles surround even the penile tissue here. We have, again, the gluteal muscles, but then we also have bulbospongiosis. We have the bulbospongiosis goes all around the entire part of the base of the penis. And then we have all different kinds of muscles that wrap up. So the bulbospongiosis helps with erectile function, ejaculation function. It's really important that we look and address sometimes these muscles and their function, as well as if they're tight or have problems in that way. And this gets missed a lot, unfortunately. It's something that a lot of people aren't trained in. So someone will just be labeled with, oh, you must have prostatitis, or you just have tight muscles and you just have to live with it. Or you've had prostate surgery, so there's nothing more we can do. And I'm here to tell you there are things we can do. We also look at function. We want to know, we don't necessarily watch you on the toilet, by the way, but we are looking at function to say, how are you doing with your toileting? How are you doing with your bladder habits? We look at all these things as well. We look at the whole person. What are you eating? What are other things you're doing that contribute to your symptoms? And then we sometimes offer things like dilators or other things for home use so that a patient can progress. And again, I think having guidance with this is so much better than just going online and ordering things. So understanding what you're going to be using and how you're going to use it can be super helpful for the patient. And as Dr. Rubin stated, we do have, if you're saying, well, how do I find a pelvic health professional? We've been growing this is totally a global site for pelvic health professionals. We do have physicians, but it's heavy on pelvic health therapists. So I think that would be super important to know. We have pelvic physical therapists, pelvic occupational therapists. We have sex therapists, sex counselors, a variety of fitness professionals that also focus on pelvic health. So and then again, physicians. So we have lots of different pelvic health professionals here. And if you don't see yours, that your favorite one, if you don't see them in here, make sure you tell them to get in this directory because we're constantly growing it. And then there's a pelvic health screening tool that we've developed, and that's in the blog area of our website. So that's, for example, if you want to say, like, do I have a pelvic floor problem? Should I contact someone? Or you can take this to your physician and say, these are the questions. So it'll be questions like, do you experience leaking with urine? Do you experience sudden urinary urges? Do you typically urinate more than 2 hours? So there's these questions that help guide that you can say, yes, these are the problems I'm having. I think I need to see a pelvic therapist. And we've had this so it's really easy for you to bring into your physician or for the physician to realize, oh, this is someone that might have a pelvic floor problem. So it can be used for anyone just to identify, is there potentially a pelvic floor problem going on here? So I thank you for your time here tonight, and I hope that this was helpful. I look forward to the Q&A so I can see everyone or hear the questions at least, and I would love to know what you're thinking and what questions you have.
I just love hearing you speak, and I love the pictures. I mean, I can't tell you how those pictures have transformed my practice to be able to show them with patients and say, okay, this is what the body looks like. This is the nerves, this is the muscles, these are the arteries. Where is your pain? Let's look at it. What lives here? Is it moving somewhere? Is this part of it? And what's so cool is, Tracy's developed abilities for us to say, wait, we don't have this picture. Can we get this picture? And they're always adding more things, which is very, very cool. Alexa, you can come back. We love you. We want you to join this conversation too. I don't see too many questions. I don't see, Alexa, since we don't have any questions that I see, and Kim's here, which is so great.
We do actually. We have a ton
I just
of
can't
questions.
see them. Oh, good.
And
I can't
yes,
see them.
John is joining us now too. John, I know that there was a topic that we discussed at the beginning. Could you start us off with that?
Hi, I'm John Antonucci, and Kim and I are going to help with the question and answer section. Kim will pay more attention probably to things like multiple sclerosis. I'll pay more attention to things like cancer, and particularly prostate cancer. And what Alexa is talking about is that a lot of people have written questions in when they registered. And quite a surprising number of people asked about if there's a role for prostate massage in pelvic floor therapy. And it's kind of a mystery. So would anybody like to take that on for us?
Yes, I would be happy to share. It's actually one of the biggest topics that does come up quite a lot, and I will explain it to the best of my ability. And then I know, Dr. Rubin, you might also have your experience on the urology side of it. So if someone is having any kind of pelvic pain, when they have a prostate and they're having pain, if you start Googling, you'll see that often in research it shows up as prostatic massage can be helpful. So they'll say there's a lot of work out there that says prostatic massage can be helpful. And this goes back from even book articles and things that are written. So what happens is someone will call a pelvic therapist office and say, hey, I'd like to get a prostate massage. And the therapist says, wait a second, we don't massage prostates. We don't do that kind of thing, because in the articles, it'll say you want to milk the prostate essentially until there's some sort of fluid that comes out. But we don't do that in therapy. So sometimes they say, oh no, I will not see that person. They just want me to touch and massage their prostate. So I think what's really helpful to know is that there are ways to mobilize and touch around the prostate that can be very helpful for pelvic pain or congestion in that area. So what I tell the therapist to say is that we absolutely are trained and we can do prostate mobilization that can be very helpful in some cases, but we don't do prostatic massage as it's seen in some of these articles. And that's a way for us to explain we can in fact help them instead of turning people away and thinking that they're saying something strange, but we can offer that. Now, I've heard that it's been phased out a lot, the prostatic massage, but I'd love to hear Dr. Rubin's take on that piece of it, on the prostatic massage.
I think you hit it out of the park, and here's where language matters and understanding the anatomy is essential. And urologists have not understood the anatomy forever, right? They're only now beginning to understand the importance of the entire pelvic floor. So my colleagues, love to give out diagnoses of prostatitis, where most of the time it's just dysfunctional pelvic floor, tight pelvic floor muscles, which create all of the symptoms of urinary problems and pelvic pain problems. And so the physical therapists get it much quicker than the doctors who don't get it, unfortunately. And the patients, of course, they have no idea what they're asking for because they don't know the anatomy. They don't know, and it can be very shaming of, oh my God, we don't do prostate massages. You sicko, right? You just want, to orgasm, when people just want to feel better, and they want education, and they want to understand what's happening. And so I think, Tracy, you're exactly right to just reorient them to like the education piece of like, no, like this is what I think is going on. I think we're talking about the same thing and just using different words. And then I think you should come in for an evaluation, because I think we're going to explain this to you in a way that really makes sense. And the problem is, part of the reason I yell so loudly on social media is to get doctors to understand that we didn't learn this in urology school, and that the old school urologists who trained you didn't understand it either. And so when I was in my training from 2012 to 2017, I wasn't introduced to a single pelvic floor physical therapist. I wasn't introduced to a single sex therapist in my 5 years of surgical urology training. And then when I got into practice, I knew all of them, and I knew every single one by name, and they all had my cell phone number because they were the ones who were getting my patients better, not me. I was just shuffling, giving them the education and then saying, oh, you got to go see Hannah down the street because Hannah specializes in post-prostatectomy issues. Oh, you got to go see Jen because she really gets this piece of things. And the more I got to know the pelvic floor physical therapists in my area, the better care my patients got, and they understood sort of what the connections were. So anyway, I agree. Did that answer the question, John?
Yeah, well, I think so. I didn't see a lot of the questions, but I think it did. I want to.
I also add something.
Ahead,
is that I think this is something that I wish there was more research on, but again, just doing this for 23 years, and I don't even know, we haven't even talked about this, Dr. Rubin, so I'd be curious to see what you think, but there's pelvic floor muscles that are dysfunctional sometimes, but also if someone's had a history of UTIs or some kind of scar tissue or any kind of surgery or operations or anything in that area, it creates an inflammatory cascade around the prostate or around the urethra in women. And I think sometimes that's why when I was talking about prostate mobility, it's not just even the pelvic floor muscles. It's actually also when I actually go,
right? It's visceral. Okay.
Yeah, I do more visceral, like organ mobility. And patients say it's the first time I've been able to have full ejaculate again. It's the first time I've been able to have a full erection again. It's the first time I've been able to have a full stream. And it's because we're working on the muscles as well as organ.
Nobody questions you get a knee replacement, you get PT 3 times a week, but if anything happens to your pelvis, no one talks about rehab. This is rehab, and it really works, and doctors don't know anything about it, literally nothing about it, which is the fascinating piece of this. Go ahead, Kim, you look like you've got a question.
I got some fabulous questions from the chat, so I'm super excited to tell you guys all. Thank you so much before we start, Dr. Sher and Dr. Rubin for doing this tonight. For anyone like me that has cognitive issues, is freaking out like, oh my God, so much information. Don't worry, this is being recorded and it'll be sent to you if you're registered later on in your email this week. So the first question I have from the chat is this something that we can sign on to for future needs, or is this just a one and done today?
These kinds of webinars or pelvic floor physical therapy?
A pelvic floor physical therapy.
Yeah, go ahead, Tracy. Do you just go for a one-time evaluation?
I gotcha. So this is, I mean, the way I do it might be a little bit different, but typically we know that with most pelvic floor disorders, there's some sort of, some will say anywhere from 6 to 12 sessions can be helpful. But now I might have a patient that can only come to me a few times, and that's great. Then what I'm going to do is an evaluation and then give them some tools, and we'll figure out, okay, you're only able to come in 2 more times. I'm going to give you the best information I can. But typically therapy is usually 1 time a week to once every 2 to 3 weeks. And you do that over a few months. And that can be really powerful. You don't need, if you hear someone say you're going to need to be with me forever, or you're going to need to be here for 2 years, that's not necessarily true at all. It's usually a very short period of time, but really focusing within that, usually once a week or once every other week or so. Yeah.
Excellent. Dr. John?
I wanted to, before I get to the questions, and I have lots of great ones here too, I wanted to say how much I appreciate the idea of healthcare professionals talking to each other, both across disciplines and across specialties. When I was trained to pick up the phone and talk to everybody that's on the case. If I had somebody in the emergency room, to call their doctors. Over the decades, I think that has gone out of fashion. And now when I tell a fellow or a resident to call the person's doctor, they kind of look at me surprised. And I'm really sorry about that, because we are a network that have to work together, and fragmenting care is bad for us, and it really frustrates the patient. I think the patient has come to be given responsibility for communication between doctors. And you guys are working directly against that trend, and I wanted to say I'm very glad to hear it. As far as the questions, I'm gonna take up the topic of embarrassment, because I've got questions like, does a man have to see a man therapist, and does a woman have to see a woman therapist? And what about the business of embarrassment? When people come in for their evaluation, and it was true in my case, I'm not sure they expected to get the therapist's hands all over their private sections and get, pads and electrodes stuck onto embarrassing places and pull their pants down and things like that. Maybe the expectation is that we were going to stay completely dressed and The diagnosis was going to be done by talking, and the treatment was going to be done by giving us instructions. So could you speak a little bit? The reason I'm bringing this up is because I'm afraid it might keep people from coming to see you.
Yeah,
so could you talk about not only how you deal with that, but how we who refer people can deal with that?
Yes, I think this is a great topic too, because we're so used to and comfortable with pelvic health that we just do want to kind of dive in, but it's important for us to remember too, that to hear this side of it and to know that there can be these concerns. The approach that I teach and I think works really well is to say, these are the things we can offer today. We can offer just talking. Sometimes we just say, if you just want to talk today, that's totally fine. If you are open to this and feel comfortable, I can do an external exam to see what's going on with the muscles and the other components around. Or if you'd like, I actually am able to do a full exam that would include internal muscle testing or, like you said, a machine type testing, but I only do it to the patient's comfort level. And so you as a patient would have every right to say, hi, I'm here today and I'm really nervous. And I really know I have this problem, but this is even hard for me to talk about. Can we just talk today? And I will guarantee you, in most cases, they would say yes, absolutely. And if someone is pushing you to do more, that's maybe not then a good match for you, because we should meet the patient where they are. And so when we tell physicians what to expect, it's under that same idea that we have the full capability to do all of the things within one exam, and we can do a variety of different testing. But we certainly meet patients where they are, and if they aren't ready for that, I've had patients where we go for the first 4 sessions and only just talk, and they're happy with that. I'm happy to talk to them. And then and again, we don't know, we need to know history. There might be trauma history, there might be some other abuse history. So there could be a lot of other things too that we want to take into account and do trauma-informed care. So it's layered, and each person is different. And so I think the more that you know that you don't have to immediately, like you said, drop your pants or something like that. In most cases, you can say, I'm not comfortable with that today. And then see what they offer, some things you can do at home or some exercises you can start with. And most of the time, we're very capable of doing that.
I couldn't agree more. And this is where education is so critical, because at the end of the day, your elbow doesn't give you shame and disgust and ickiness, right? It's a neutral part of your body. And how, as clinicians, we can really empower our patients to say, your penis is a muscle, your clitoris is a muscle. Like, this is no different than your hips and your low back and your shoulders. And we are professionals, and nothing you show us is going to surprise us or gross us out or make us uncomfortable. Society has called them private parts and made us all feel shame and guilt and ick factor, but we have to fight against that. So I do a lot of, again, meeting patients where they are to really understand how they feel and give them the power to say, okay, I'm comfortable with this. And then the next time and to know that you're the boss, you are the CEO of your body, you get to decide what we do and how we move forward. But at the end of the day, you want to fill your team with professionals who just want you to get better. And that's what the pelvic floor physical therapist is there. They are the professionals who are there to treat your pelvises like it's any other musculoskeletal part of the body, and they get you there, right? That's what's so fun about it, is they will read the room and say, okay, let's get to know each other, let's talk about the story, and then we'll go at your pace. And that's, again, why I fell in love with pelvic floor physical therapists, because they add so much value to my patients' lives.
And by the way, on the flip side of some of this, I have patients that say, okay, I'm going to leave the room. They're like, no, you don't even have to leave the room. And I'm ready to do it all. I've been waiting for this moment. I want to get everything done in one time. So we have every extreme where I'm trying to be very careful and respectful, and they're like, let's go, so you see both sides of that.
It must be a great relief for many people to talk so openly about these things where they never have been able to before.
It gives a space for people to just speak freely, and the more you show up, and that's why we love doing videos on social media, because people they can voyeur, they can see us out there and see how we interact. I had a woman fly in from Texas recently, and she said, I've watched every video you've done, I've listened to every podcast, and the real thing was so much better than I ever imagined, and it mattered. And she knew, she already had the know, like, and trust. She felt comfortable with me. So once we had our in-person visit, we started from a different place of already sort of knowing each other, which again really helps, because you know who you're going to be talking to. So a lot of physical therapists have great social media presences, and you can kind of see the person's vibe, and you know, just like a good mental health therapist, it has to click. If you don't feel comfortable, it's not the right fit, and that's nothing wrong with you, and it's nothing wrong with the PT. Just like I don't like watermelon, right? There's nothing wrong with watermelon. I just don't like it. And so it's not always a good fit.
And on that note, you might have to try different people. So, you know, some people say, oh, physical therapy, pelvic physical therapy didn't help. And it's not a modality. It's not like you try one thing and it doesn't work. It is also considering, like, is this just that person didn't have the experience, or there wasn't a click, like you said, personality wise. So sometimes it takes a few tries to get the right person. So also don't give up for that. If you finally get to that place and then say, oh no, this isn't for me, it may just be another person to work with.
And that's true for medical doctors too, right? And the idea that we think that one doctor should know how to do everything, right? They don't make them like they used to, Dr. A, right? Like no one doctor is going to be able to do everything for one person. And so you have to build your team, and you have to advocate for yourself to know if it's the right team member. So your cancer doctor or your MS doctor may not be your best quality of life doctor, right? You may have to add other people, you know, to that team. And sometimes it's not a doctor, you know, a medical doctor. Sometimes it's a doctor of physical therapy. Sometimes it's a doctor of sex therapy, right? And really working with the people who specialize.
Kim?
I just want to add one thing to this conversation. When I went to see a pelvic floor physical therapist, one of my appointments fell on when I was having my period. And I'm like, I'm having my period. She's like, I wear gloves. It doesn't bother me. So whatever you're comfortable with. So I just want to let the ladies know it's okay. This isn't like a PAPS. You're good to go. Show up.
Yes.
That's not an excuse not to go.
And that's a great point too, is the way we word it is we absolutely don't mind. It does not affect us. If you still want to come in, go for it. If you feel like you're not comfortable with that, absolutely feel free to cancel and we'll reschedule you. We don't ever say you have to come in. It's your appointment. We definitely want to make that option for patients available.
Okay, let's do the next question. I apologize if I butcher this term. How can pelvic floor PT help with vulvodynia? I'm assuming like vulva pain?
Yeah. So vulvodynia is one of those diagnoses that we both, Dr. Rubin and I, know very well. It's essentially so if this, I use like my hands a lot. I should have had I usually have all my models ready. I don't know why I didn't today. So if this is the opening of the vagina, that layer here at the opening is called the vestibule. And the whole area is the vulva. Okay, that also includes your clitoris and this whole area here. So vulvodynia can be any pain in this whole vulvar area. But a lot of times what's happening is something called vestibulodynia, which is even more at this vestibule here. And that's vestibulodynia is kind of under the umbrella of vulvodynia. So the question is, what was the question?
How can pelvic floor PT help with that?
Okay. So with vulvodynia types of cases, there's sometimes a medical component that needs to be addressed. It could be something like a cream or some other kind of medication that's used, but often the actual pelvic floor muscles get tight and are problematic as well. So what happens if we're only treating the medical component of it, someone might still feel like they still have vulvar pain there. And they're like, why is it not getting better? And the missing component is that we're not addressing the pelvic floor that became tight. So when we're addressing the muscles around that area, the superficial transverse perineum, the other muscles surrounding here, when we work on those and help relax those in a variety of different ways, you may find that, oh wow, now I'm finally feeling better. So pelvic floor physical therapy is addressing the pelvic floor component of the vulvodynia, along with the other thing too that we do very well as pelvic therapists that sometimes gets missed is, like I was saying, we're a case manager. So we're essentially saying, okay, let's talk about sexuality and things that you want to do there. We might introduce dilators or ways to relax and breathe. So we're looking at the entire person, not just the pelvic floor. We're trying to figure out how can we help this person with all the functions that they have in terms of their life, and how we can help them with all of those things. And vulvodynia can affect sexual health and other functions as well. So we address all of that.
And to Dr. Antonucci's point of us working together is I have seen over the last 5 years the incredible advocacy that our groups have worked together. So the physical therapists are saying, ooh, there's a hormone problem here. The tissue looks dry and irritated and tender and really tender to the touch. And yeah, your muscles are a mess, but your muscles are reacting to the fact that this tissue lacks hormones. And the vulva, the urethra, the pelvic floor, the bladder, they have lots of hormone receptors, both estrogen and testosterone. And so it's often the physical therapists who say, ooh, I know your gynecologist said you should just use lubricant, but I think you need something a little stronger that will fix this problem. Maybe you should look at this YouTube video that Dr. Rubin did, or look at this thing about vaginal estrogen. Have you seen this tweet? To give people information that the tissue health is really important. So it's that teamwork. I tell my patients that I can't fix you completely. I can fix the tissue hormonal problem, and then the pelvic floor physical therapist is a 1-2 punch, will help get the muscles to relax and know they're not in danger anymore. So first we have to turn the fire off, and then we can get the muscles to relax so that you can, enjoy your organs again.
Yes, exactly. It's great teamwork.
I have a question about whether climacturia can be treated, and my version of that question is, how can you hold on and let go at the same time?
Oh, such an important, frustrating thing. Climacturia, Tracy.
Yeah, do you want to start with that?
Well, it's a very, again, it's a very challenging one. I think pelvic floor physical therapy is incredibly important to control that squeeze, and sometimes it's possible. So really working with a specialized pelvic floor physical therapist who is not afraid of the penis, because a lot of times there's training only rectally and that part, and there are only a handful of physical therapists growing who are able to really work on the bulbo muscles, the ischio muscles, and this, sort of that connection. But sometimes muscles get damaged in radiation and surgery, and no matter how hard we try with the muscles, it doesn't fix the problem. So urine never hurt anyone, but urinating before orgasm is keeping your bladder empty is helpful. Wearing a condom can be helpful. Wearing a constriction band or cock ring can be helpful. Sometimes a male sling surgery, when really physical therapy is not working, can be very, life-changing for patients. So from a doctor's perspective, you have a toolbox, and we sort of work within that toolbox. What would you say, Dr. Sher?
Yeah, I think too, it's like you said, really understanding the anatomy. I find that even understanding where the points are, the dorsal aspect of the pudendal nerve is lying in a certain area near the pelvic floor, as well as the prostate area. And I think even understanding the anatomy, how that can affect the whole chain of events when we're talking about that condition. And again, like you said, all the muscles around bulbo, and feeling comfortable sometimes being able to touch and feel around the bulbospongiosis and the muscles around the penis itself. So all of these things, it really is important to know that the more someone feels comfortable and understands the anatomy, we can do more to help them. So that's what I was saying. Again, if someone doesn't feel comfortable, don't assume that no one can help you. You just might have to find someone else that feels really comfortable with that anatomy and those diagnoses. Ask them, say, do you feel comfortable treating this? Is this something you treat often? And you'll find out if they really do feel comfortable or not.
Can you define the term climacturia in case we left anybody in the dust?
Yes, climacturia is that climax, and urea is urine. So at orgasm, you leak urine, and it may be a female who does that, and maybe a male who does that. A lot of prostate surgeries will find, you leak with orgasm, and as opposed to just leaking coital incontinence, which is when you leak at any point during the sexual encounter. So each one has sort of different treatment modalities with it. I will say, I think we are going till 9:30. I'm so apologizing. I double booked myself and have to run to another event for students because I have to teach students and the next generation of people as well. And I thought we were going till 9, and I guess we're going till 9:30. So Tracy, can you stay and continue to answer questions? And I'm so grateful to AnCan and for all of you who are joining in. This is really just an incredible organization that I hope you can support.
Thank you so much. Nice to see you.
Thank you.
And on that note, just so you know, with the leaking part, that's where it does matter in terms of, was there surgery? Is it the muscles that are affected or the nerves? That's why I was talking about the pudendal nerve is really important there. So just to know that we're also we're doing a lot of investigations to figure out, is this a nerve issue? Is this that's been affected? Is this a muscle issue? Is this a timing issue? So there's lots of different things to look at with each of these cases.
Okay. The next question, another term I'm going to probably butcher the pronunciation with, is what is the difference between vaginismus and hypertonic / overactive pelvic floor muscles, or are they the same thing?
Wow, y'all are coming with the questions. Okay, so
they are. Keep coming, guys. Keep coming with these questions.
So hypertonic or overactive muscles are essentially tight muscles. They're staying in a tightened state. You can have, so vaginismus is, if you think about the vaginal opening, here we go again with the diagram here. What happens is anytime there's an attempt to have, let's say, a tampon go inside or a penis, there's an immediate reaction. And it's similar, the way we describe it is if someone's trying to put something in your eye, you're automatically going to blink and stop. It's just a reaction. So, and with time, for those of us that wear contacts, we're aware that now I always joke and say there could be a large fly flying into my eye and I probably wouldn't even blink, right? So we get used to just putting in our contacts, we get used to that. So there's a way to retrain the muscles so they don't go into this contraction. So someone can have hypertonic or overactive muscles and just be tight, but not actually have that vaginismus response. But someone with vaginismus, that response actually probably has hypertonic and or overactive tight muscles as well. So that makes sense. So you can have tight muscles and not have vaginismus, just have pain or tenderness in this area. But if you have vaginismus where there's this reflexive response, chances are there is some form of tightness of those muscles and overactive type of response to the muscles. So hopefully that's helpful.
There are so many questions about the effects of radical prostatectomy and radiation on sexual function, ejaculation, incontinence, that that maybe you could just give an overview and cover a lot of people's questions at the same time.
Yeah, I think just in general, I'll say about radiation effects on the pelvis, regardless of what kind of parts we have. I think that's one of the most challenging things because, as we know, over years, you can continue to have changes in the tissue. It's not something that just happens once and then it's done. You consistently may have changes. So when there's function changes, it's really dealing with each person individually and figuring out that radiation effect. So for example, when we're working with someone who has had, I'm trying to think of an example, brachytherapy for the vaginal area, and so they're having they're having radiation effects inside vaginally. There might be some fibrosis or changes, so we're trying to see if we can stretch the tissue and keep it mobile so that it doesn't just continue to have fibrotic effects. And if someone is dealing with radiation, prostate, around any kind of prostate type of surgery or prior to that, even radiation in general, what we find is that, again, addressing each person's function. So do we need to look at their pelvic floor strength and ability to contract? Do we need to look at the tissue itself and work on the tissue so that it stays as mobile and stops getting as fibrotic as possible? And again, you're kind of working against a process that's in place. So it might not be perfect, but we can certainly do things to help. And this is where, again, I think that the more someone knows about it, I don't do as much of it now, but years and years ago, I worked with Vit Patel, who was one of the top prostatectomy surgeons. He did more prostatectomies than anyone else, and he's here in Central Florida. So we were seeing a high volume of prostatectomy patients and also those who had had radiation. And I found in that time that I was seeing people, the quality of life was a lot better when we were addressing the muscle tissue all around the whole pelvis. So the abdominal wall, the outside of the pelvic area, internally, rectally, in that area, as well as the function, contraction of the muscles, relaxation of the muscles. It did make a difference in their quality of life. So hopefully that answers the general question about that.
How about that answers the radiation part, although there was a question about whether scar tissue can affect continence or erectile dysfunction. That may be referring to scar tissue caused by radiation, or it may be about radical prostatectomy.
Yeah, any kind of scar tissue is essentially like sometimes I show patients if there's a sheet, it's basically just crunching things up, so it does affect function, right? So if my hand, I'm trying to open it up, but now I've got this scar tissue here, it's going to make it harder to function. So what we want to do is try to, again, within each individual, see if we can mobilize the tissue some, but then also help them with the function they have around it. So it can affect different kinds of functions, but it doesn't mean it's necessarily, you know, going to be detrimental. It just depends on each individual. So the goal is to constantly see if we can help move the tissue and keep things moving, as opposed to just letting it continue to get into that state that scar tissue wants to keep closing down. So it's kind of, you're playing against it as much as you can. It's kind of like a race against it.
Kim?
In what cases would you need an anal rectal exam?
In what cases? Oh gosh. So for those that we want to access the pelvic floor, okay, so I want to be clear. When we look at pelvic floor function, I can look at anyone's pelvic floor function on the outside and get some idea. So I can look at them from outside without doing any internal vaginal or anal rectal exam, and I'll be able to tell some pelvic floor function. But the gold standard for really knowing what's happening with the contraction and relaxation and the tightness of the muscles or how weak they are is to actually go inside. So when we're looking at someone who it has a penis, prostate, or penis and testicles, that anatomy, the only way to really get to inside the pelvic floor would be to do an anal rectal exam. That's an example. So we would go there. Let's say you have someone that has a vulva. What would happen is we have two options. We can potentially do vaginal exam to see some of the pelvic floor function, or we can do anal rectal. But now let's say that person says, I have constipation and I have rectal pain. Then if I were to choose, I'd probably focus more on anal rectal, but I might end up doing both if they're open to that. And again, we only do that if this is a patient that's open to that and wants to try that. It's not something that it's mandatory. There's so many things we can do to teach without doing that. But those are just some examples. So it really depends on where the symptoms are, as well as what anatomy they have to access the pelvic floor.
Thank you. Dr. John?
Rachel mentioned the sling, and some of us have had AUSs, and both of those can leave a person with some residual incontinence. Does that change the therapy? Can you still do, is it good to still do Kegels after surgical procedures like that? Or how does that change the picture?
Yeah, I think there's still, even with those procedures, it's still good to have the best pelvic floor function you can have. So yes, it's still good to understand your pelvic floor and what you can do to augment it. Now, I will tell you this, you know, sometimes if someone feels like they're gonna sneeze or cough and they're gonna leak, what they tend to do is I can't do this right now, but they tend to squeeze everything. They squeeze their legs together and they grab everything together. So we actually use that to our advantage in pelvic therapy. So for example, if someone has had a major pelvic surgery and they're not able to even access their pelvic floor muscles, what we do is we teach them how to actually access the inner thigh muscles, the gluteal muscles. So there's still a lot we can do to teach people how to strengthen around the pelvis that can still help support for incontinence as well. So it's not even only pelvic floor. We do a lot of the entire pelvic area to support that continence factor as well.
Thank you.
You're welcome. And again, it's tricky because every case is so different. So we have to look at the person's full history and what they're presenting with so that we can create their own individualized plan.
How can pelvic floor PT help with sexual dysfunction with multiple sclerosis?
Ah, okay. Well, with multiple sclerosis, it really depends on how it's presenting. Because we know there's a huge factor of muscle spasms, right? So what we're trying to figure out is, first of all, what medications are they on and how is that already affecting? So is there a baclofen or what's on board already? And then we're trying to figure out, is there actually, in fact, this hypertonicity we were talking about, a true hypertonicity or overactive pelvic floor going on? And usually it's not just isolated to the pelvic floor. We see this across all different muscles, right, that are lower trunk muscles and all of that as well. So a lot of times we're dealing with a lot of diaphragmatic work, opening up the diaphragm here, the abdominal wall, a lot of mobility around the abdominal wall, the pelvic floor muscles. So we're doing a lot to help their function. And like I said, it tends to be more this hypertonic type of stuff that we're working with. But there's also weakness components. There's gait components too that might be affected. So it's looking at each individual and figuring out in their case, and what are their goals? Is it sexual function? Is it urinary? Because then sometimes you present with a neurogenic bladder or some sort of problem with leaking or an overactive bladder. And that's a little bit different when you have MS because we're dealing with a neural component. So this is what I tell my patients with MS. I say, just because you've been diagnosed with MS doesn't mean that you can't still get support with pelvic floor help and overactive bladder. It just might look a little different because we're working against a neurologic component as well. It's not simply just strengthening, it's also figuring out how to work around or compensate around this neurologic component.
Now, I'll add on to that question. One of my friends that has MS that uses a wheelchair, she was wondering if she can't feel her muscles at all. And she was wondering if pelvic floor physical therapy would help. And then she was trying to think of things like, it was like Pericoach and like Ellatone, when anything, those kind of things, would those be helpful at all, or?
Yeah, so that's a tricky one because there's two kinds of things you can do at home or in a clinic, and actually it's worth discussing. One of them is these Pericoach or Kegel, or I'm trying to think, there's many on the market where it's basically you put it inside and it's like a video game, and it just tells you to squeeze, and then you see it go up and then squeeze. So that's a form of biofeedback. Okay, EMG biofeedback, where essentially you're squeezing around something and then you see the thing go up. Then there's electrical stimulation, where it's essentially you put something inside or even on the outside around the anus, let's say, not even inside. And what happens is it's stimulating, it's providing an electric current essentially that's stimulating the area and creating the ability to have contractions. So there's some debates about this, because if someone doesn't have sensation, that's one of the things they say preclude you from using e-stim. If you're not able to feel that area, they get nervous about you having electrical stimulation there because it might be too much for that area. But there's absolutely nothing wrong with having something where you put something there and you're still trying to learn how to squeeze. What I like about that, similar to what I was saying earlier, is that because I'm not giving any kind of electric current there, what I can do is I can have the person squeeze. And if they're having trouble, I can say, okay, now I want you to put a ball between your legs and squeeze that. And that might be enough to augment or have them start to contract their pelvic floor. So even if they can't feel it, this is what I was saying, we can compensate. We can have them use other muscles and even something like that, so they can still see on the screen, oh, it did go up. So even though I'm now using a different set of muscles, I'm still getting my pelvic floor to contract. So there's some really cool and creative ways you can do with that depending on each individual.
So it sounds like you would recommend her to see a pelvic floor physical therapist.
Oh yeah, I highly, this is the thing, people say, oh, well, I have MS, or so I might not be as effective. We can still figure out ways to compensate, or some things that we can help with that really can be helpful in each person's case. Yeah. Thank you.
I'm glad that question came up, because I was wondering how you felt about people using these devices at home. Particularly if they buy them on Amazon or something like that.
Yeah, so I'm not just saying this because we want business. It's more like sometimes it's helpful to come see us first, even one visit, just so we can teach you how to use it and feel comfortable with it. Because one of our biggest issues is we have people that buy these things and then do thousands of Kegels a day thinking that's good for them, and then they end up creating another pelvic floor dysfunction. So if we say to them, don't do more than 30 a day, and we teach them what to do, it can be really helpful to give them the parameters. But absolutely, there's ways that you can train at home that, as long as you know how to use it correctly. This is the other thing, that some people think they're doing pelvic floor contractions, and you watch them and they're doing this their whole body, right? So then are they really getting the proper use of that at home? So that's why, if you can just make sure you're doing it correctly, that's ideal. And I know not everyone has access to pelvic therapy. And by the way, it can be expensive, and there's insurance, there's all sorts of things that can be barriers. So this is why we try to do so much education as much as we can. And I really want to get more patient education out there, because we know that not everyone has the same access. We're fully aware of that, and it's really an issue that needs to be worked on more.
So you can do too many Kegels? There are many athletes who know that you give them a job and they will take it to the hill.
Yep, you can create a pelvic floor tightness and pain issue by doing too many Kegels, or they have vaginal cones you can put inside and hold, which is, again, okay for 10 minutes, but if someone's using it for hours and hours at a time, they can develop problems where it becomes too tight, or problematic in that way. The good news is you can reverse most of this. It's just, it's not good to do too many Kegels, correct?
I have a question whether there's any place for acupuncture as an adjunctive treatment for pelvic therapy.
Yeah, I like that question. So I'll put on my research brain for a second. The research doesn't support, it's not like overwhelming, everyone should do acupuncture. It's kind of like, is it placebo? What is it doing? And I will tell you this though, aside from that, There are patients that distinctly work well with acupuncture. It helps them tremendously. So what I feel, it's like a way of a neuromodulation for some patients. If they have pain and every time they go to acupuncture, they feel better, it's there, somehow their nervous system is responding really well to it. So I think that's an excellent adjunctive therapy for them. There are other patients who feel compelled to try it and they're like, well, I guess I should go for another year just in case. But I tell them, if it's really not helping them and they're not seeing a symptom change, whether they're trying to do it for urinary leakage or pain and it's not helping them, they don't have to feel obligated to continue. They can certainly try it, but it's not necessarily, I don't say you have to do it. It's just something to try. But some people really do find it helpful. So then I say go for it. Yeah.
Okay, they wanted us to ask about how to get a referral and if insurance covers it.
Okay, so that is another great question. If you get, so this is the thing, if you ask, so let's say you're at a hospital, you're seeing a physician and you say, I would like to try pelvic physical therapy. The things you need, the only things you need to have on a script, so if the physician's like, I don't know what to do, I don't know how to get that, the things you wanted to say is pelvic physical therapy for, and then the diagnosis. So whether that's urinary leakage, prolapse, whatever the case may be, pain with intercourse, whatever that case is, you put in, they put in the diagnosis, the date, and I think, and then the physician signature. That's really all we need. You know, they don't need to say how many times per week. They don't need to say what we need to do. We take it from there. We have all the ability to decide what we do with that patient. So that's all we need on it: pelvic physical therapy, and then the diagnosis and the signature and the date. And then the next question becomes, and by the way, there are going to be some people that are more amenable to saying, sure, I'll sign that for you, and others you might have to look and find someone else that will write that prescription for you. Again, don't give up. If you really want to do it, just know there are physicians, primary care physicians or other physicians that might be willing to write those scripts. I believe we can even take it from chiropractors and even dentists, believe it or not, for pelvic therapy. I don't understand, but you can. So, and nurse practitioners as well in many states. We can have nurse practitioners sign it as well. So there are a variety of professionals that can sign that. And then insurance is another tricky one. There are a lot of us that don't get reimbursed very well for therapy for the amount of time we give patients, because we give them that good hour. So we don't get reimbursed for, it could be only 10 minutes of our time. So many people are considered out of network. So this is where I was saying you might only get to do 1 to 2 visits if they're out of network, but it might still be really worth it for you. Instead of thinking I just can't afford it, just tell them up front, I'm probably only going to be able to do 2 sessions based on this cost. Is that okay? But then also there are providers at hospital systems and other places that do take insurance, and all types of insurance. So they are pelvic physical therapists and pelvic occupational therapists that absolutely do take insurance. So this is where you might want to look. If you look at, like, for example, on our directory, some of the write-ups say out of network, some of them say we take all of insurance. So you might want to also contact them and say, do you take my insurance? So it's similar to a doctor's office where you might just have to see if they take your insurance or not. So yes, it's both out of network as well as in insurance. It depends on the provider.
I got a question about ED. Is that okay for you, or was that for Dr. Rubin?
Yeah, I mean, it depends what it is, but it might have been more for Dr. Rubin, but let's see what the question is and I can let you know.
Well, the way it's worded is there a specific therapy for ED?
So whenever I have a patient who comes in for ED, there can be a component that is pelvic floor, but there's so many other considerations first. For example, cardiovascular health. We want to look at overall general health. We want to look at, are there other factors that could be going on? So if someone comes in, they haven't had a workup at all by a urologist or a cardiologist, I definitely refer to urology and cardiology first. Because usually, by the way, erectile dysfunction, I can't remember the exact statistic, but when someone has erectile dysfunction, if it's related to prostate surgery, it's very different, right? Of course. But if it's related to just out of the blue, they have erectile dysfunction, then it could be some kind of cardiovascular issue. But if it's related to, let's say it's related to prostate surgery or some kind of prostate cancer or pelvic cancer in general, I find that those cases may in fact have a pelvic floor component. There'd be a nerve issue or a pelvic floor component. And then absolutely there's a place for us to work on the pelvic floor, strengthening again, getting the function better again. Like I said, sometimes even just mobilizing around where that pudendal nerve is, and the prostate has a huge effect on erectile function. So it really depends on the underlying cause. And I like to know the history first before I say, absolutely, we can help. It really depends on the history.
In many of our guys' cases, it really has to do with nerve damage after surgery.
Yes, and on that note, because again, there's so much nuanced stuff with the nerve stuff, you know, when they talk about nerve sparing versus not these kinds of surgeries, I find that some people do have extensive nerve damage. And then we're kind of, this is when I guess Dr. Rubin could have talked more about, you know, in terms of what they do with the pumps and different things, because I feel like we can take patients to some places and then it gets to the point where there might just be some nerve issues there where we simply, or, you know, we're going against the grain a little bit there. Yeah, unfortunately.
Thanks.
You're welcome.
Okay, she said I had one more question, but I want to sneak two in real quick. So one gal is an FNP, and she does with 99% of GYN patients at community clinic. They have limited resources, no insurance. Is there any training that she can do to help her patients?
When you say, I'm just trying to make sure I know that.
FNP, functional nurse practitioner, maybe?
Oh, FNP, okay, like a function, or is it yeah, I think nurse practitioner, is that?
Family nurse practitioner.
I'm sorry?
A family nurse practitioner. They tend
family.
to
Thank you.
Okay. So so this is actually a great question too. What we found is that a lot of the courses for pelvic therapists are the introductory 1, 2, 3, all the courses. We allow any health professionals to join those classes. And I can't tell you how excited I am whenever we have someone that's a physician or a nurse practitioner or a chiropractor, anyone that joins our courses, because I think we need more education across the board in pelvic floor. So yes, you can absolutely do that. There are 3 organizations I think that do really great job with pelvic floor education, and that's the American, they changed the name. So it's the, I'm trying to think of what they call it now, Pelvic Academy. Pelvic Academy is part of the APTA, Pelvic Academy, and that is, they do pelvic floor 1, 2, and 3. There's Herman and Wallace. They do 1, 2, and 3. And then our company, Pelvic Guru, which is also now Pelvic Global, we do Pelvic Global Academy does more specialized classes. After you've taken 1 and 2, we do a lot more of the specialized classes. So there are multiple organizations that I would highly, highly recommend. I don't know of other groups. Ishwish did a pelvic floor course at one of their conferences lately, but like for the most part, if you really want to dive into pelvic floor knowledge, I would highly, highly recommend one of our pelvic therapy classes, and we welcome nurse practitioners.
I'd like to really thank you very much, Dr. Sher, for coming in and express our thanks to Dr. Rubin as well. On behalf of AnCan and on behalf of all the non-AnCan people that have attended, 100 and something people, we really want to encourage everybody to go visit your website, Dr. Rubin's website, and come to the AnCan website and come to groups that you might be interested. I think you'll find it very helpful. Thank you so much again for coming.
Thank you all. It was really nice to be a part of this. Thank you so much. And you can see me at Pelvic Guru 1 on Instagram if you happen to be there too. I answer a lot of.
And thank you to all the attendees.
Thank you all for having me.
I would like to say that if you're on, the cusp of do I want to go to a pelvic floor physical therapist, I want to say I went to a pelvic floor physical therapist to help with my frequency and urgency issues with urinary issues due to having multiple sclerosis, and I had like an 80 to 85% improvement. It was massive. So I say if it bothers you, go see one. And my doctor did not want to give me the referral, but he's like, I usually don't do this. And I'm like, I want it. And he gave it to me. And I am so grateful I did it because now I feel I can travel. I can leave my house. And I just can't praise enough how much pelvic floor physical therapy changed my life and made it for the better. I don't know if Dr. John, you wanted to say anything about your experience with pelvic floor physical therapy at all?
There's only a minute left.
Okay.
I benefited from pelvic floor therapy. My incontinence got better and better. And then I went for radiation therapy and obliterated much of my progress. But yes, it was definitely helpful.
And check out our MS AnCan group on the 2nd and 4th Tuesdays at 7:30 Central Time. We will be there. I will be there. And thank you so much for coming. I'm so excited to meet you, Dr. Sher, Dr. John, and everybody. And come visit us at AnCan. We can't wait to see you in the future.
Bye,
Thank
Kim.
you.
Bye, Dr. Sher.